you all know that that the lung is being surrounded by two layers of the pleura. One is the parietal pleura, which is basically lining the chest wall, and the visceral pleura, which is lining the lung. It is the parietal pleura which is supplied by the intercostal arteries, where the pressure is high, from where the most of the fluid is being formed, and most of the fluid is being absorbed from the visceral tissues. There is a balance normally about 15 to 20 ml of fluid is there in the pleural space, and this is basically because of the imbalance between the hydrostatic pressure and the oncotic pressure and capillary permeability. So these the balance between these forces, whenever they are disturbed, I mean, they are going to cause formation of the fluid in the pleura. Again, another thing which is very common is that when the removal, which is mostly from the lymphatic over the visceral pleura, if they are being choked or blocked, then also the fluids accumulate. There are certain other reasons for accumulation of the pleural fluid, that is movement of the fluid from the abdomen into the pleural space through the diaphragmatic defects. So that could also account for that. So if we take the example of anything like increase in the pulmonary capillary pressure, good example is congestive cardiac failure. Capillary permeability increase, good example is pneumonia. Intrapleural pressure, which is minus, if it reduces, then it also pulls the fluid out. Good example is atelectasis. Oncotic pressure, when it reduces, hypoalbuminemia due to like nephrotic syndrome, where there's a lot of proteins are being lost. So that can also cause pleural effusion, and that can also cause pleural effusion. That can also cause pleural effusion. But there are certain, as I mentioned to you, spatial features in or spatial diseases in which there can be formation of excessive pleural fluid, like increased membrane permeability. The most good example is uh, increased pleural membrane permeability. That is not the capillary permeability, the pleural membrane permeability, like malignancy, lymphatic obstruction, defect in the diaphragm. The abdominal fluid can move into the pleural space, and thoracic duct rupture again. This is basically, as I said to you, all the fluid is being absorbed through the lymphatics. As I again mentioned that there is a small amount of fluid in the pleural space, always these forces balance so well that we do not have any accumulation of the fluid. The amount of fluid which is there is less than 20 ml, and it is having a very low protein with few cells, and usually slightly alkalotic pH. Now, a clinical manifestation of accumulation of the pleural fluid. When there is an excess of pleural fluid, I mean, you can have signs and symptoms. Small amount of fluid may not produce any symptoms whatsoever. So patient may be asymptomatic, but if there is a large effusion, patient becomes dyspneic. It also depends upon the rate of accumulation of the pleural fluid. For instance, moderate amount of fluid accumulation, if occurring rapidly, then patient is more symptomatic because the lung is up there. And but if it has been gradually increasing the pleural effusion, then a large amount of fluid can be accommodated in the pleural space without producing any significant symptoms. There may be inflammation of the parietal pleura, which has got nerve supply, so you can have a pleuritic type of chest pain. Pleuritic type of chest pain is that which increases with deep inspiration, and you can have also cough. Now, physical signs of pleural effusion is very important because they always, I mean, in the exam, if there is a chest case, more than likely you will come across this pleural effusion. So you have to practice that. The first thing is that if there is a major pleural effusion, large pleural effusion, that on that side there will be a reduction in the expansion. There will be bulging of the intercostal spaces. There can be shift of the mediastinum onto the opposite side. There are few conditions in which the mediastinum may not shift despite having a large pleural effusion, like if there is a collapse of the underlying lung, because the fluid accumulates without, I mean, the lung has collapsed, so there can be a large effusion without movement of the mediastinum to the opposite side. Similarly, fibrothorax is another condition where the central part of the mediastinum get fibrosis, and that's why the trachea and the heart doesn't move to the opposite side. So this is another reason why this can happen, that despite having a large effusion, the mediastinum is not pushed to the opposite side. So it's commonly asked question in the exam also. Now, the other thing is that when you percuss on a fusion, you will find a stony dullness. Very importantly, what do you mean by stony dullness? So you should know from your clinical method that when you hit the fleximeter finger, I mean, you will experience a pain. This is what is called as stony dullness. If your finger hurt you, that is a stony dullness, not that you are percussing on the stone. Breath sounds will be diminished, and again, a very important sign that on the upper level, if the effusion is not total, there will be always a border, and if there is a bronchial breathing, usually audible at the upper level. Similarly, there can be agophony on the upper level of the effusion. That indicates that this is the upper lower because the underlying lung has collapsed. You can sometimes have frictional rub. That is, the true surface of the pleura is inflamed, so they will be causing pain when there is a movement. And that is a typical pleuritic chest pain. So frictional rub is basically a rubbing sound between two rough surfaces when person take a deep inspiration. Now, you can also have a pericardial rub, which is how to differentiate between, because if you ask the person to stop breathing, you will not hear pleural frictional rub. It depends upon the breathing, but cardiac you cannot stop. So the pericardial rub will be audible despite holding the breath. Now, as far as the management of approach to a patient with pleural effusion, it is the most important thing is to determine the cause of effusion. There are many causes of effusion, and to determine what has caused the effusion, the treatment will be depending upon that. The other important thing is that if there is a large effusion and the patient is symptomatic, then you have to remove a larger amount of fluid. Most of the time we do a diagnostic tap just to make out the diagnosis, but sometimes we do diagnostic as well as therapeutic tap. Therapeutic tapping of the fluid means that you are relieving the symptom of the patient. Now, this is a chest X-ray showing a classical left-sided pleural effusion. So how do you know that this is a pleural effusion? Because you will find a meniscus sign. This is a curved linear curving, which has got concavity towards the center and the convexity towards the outer side. So this classical sign is called meniscus sign. Concavity towards the center and convexity away from the center. So meniscus sign, whenever you see, the reason why meniscus sign is seen because of the capillary action, the fluid tracks on the side of mostly the fluid is at the bottom, but slight amount of fluid can track on the side between the two layers of the pleura. So this is why a meniscus sign is being formed, and it is classical of free pleural effusion. Again, you can see that here there is, if there is a fluid in the fissure, but the classical meniscus sign is there. This is all fluid here. This is all fluid here, and this is the meniscus sign, which is there. Concave towards center, convex towards the outer side. Sometimes when we were not sure, it could be a mass or something, although when you see this sign, this is a classical sign that there is a pleural effusion. Particularly if there is a loculated effusion, you may not see this classical meniscus sign, and then it becomes difficult whether it is an opacity or it's an effusion. Previously, up till for a long time, we used to be doing a lateral decubitus position. There's a side where the opacity is visible. You turn that on the bottom. Ask the patient to lie on that side. So if it is a free fluid, it will go along the wall, and you will see the change in the shape of the fluid. And this indicates that there is a fluid. If there was a mass here, white color mass, this would have not happened. So change in the shape of the opacity with the change in the position indicates that there is a free fluid in the pleural space. This is how we used to determine whether there was a pleural effusion or not. This is another X-ray which is showing a massive pleural effusion. Now, sometimes you can have a large tumor also like this, and because here turning the position of the patient will make no difference because it's a complete full tense effusion, so it becomes a really difficult, but the physical signs are so classical that you cannot miss it. Now, in the last 10 in the last decade or so, we have been using ultrasound to find out whether there is an effusion, whether there is a mass or a consolidation, because all these three things, mass, consolidation, and effusion, can produce similar sort of picture. Even a collapse, total collapse of the lung, although the mediastinum will be shifted towards the side of the collapse, not to the opposite side like in pleural effusion, but still sometimes, as I said, the mediastinum does not move, so you can be confusing this with total collapse of the lung. So total collapse of the lung, usually mediastinum is on the towards the side of the opacity, but sometimes there is no movement of the mediastinum. Similarly, if it is a big mass, the mediastinum may be pushed to the opposite side. Consolidation, then mediastinum will remain in the center. So whenever you see a large opacity covering almost one hemithorax, the important thing is to see whether the mediastinum is central or it is moved towards the side of the lesion or collapse. It is opposite side, then it is usually a pleural effusion or a big mass. If remains center, it is usually a pneumonia. So this is how we make a diagnosis. But now the life has become very easy. In the last decade or so, we have been doing, excuse me, we have been doing pleural effusions. Pleural effusion is very sensitive in detecting a small amount of effusion, the one which cannot be seen by a chest X-ray. For instance, if it is accumulation of the fluid about 200 to 250 ml, will not be visible on a chest X-ray because it goes in the back on the posterior gutter and the angle obliteration is not seen. When it goes beyond 200 or 300, then the first sign of pleural effusion appear on a chest X-ray. However, ultrasound can detect very small amount of pleural fluid, even less than 200 ml, can be easily detected. And this is how the pleural effusion looks like, because fluid is a bad conductor of echo sound, so it will become black in color. This is the liver, this is the diaphragm. All right. So above the diaphragm, there is a pleural effusion, and it is anechoic effusion. That is, there is no echoes inside the effusion. And this is usually seen in transudate or sometime in exudate also. So this also helps in determining whether it is an exudate or transudate. But sometimes you will find that there is a lot of adhesion in the pleural space. These are the meshwork formation because of the fibrin deposits, and this is called multi-septated effusion. Multi-septated effusion. There are a lot of septas which have been formed here, multi-septated effusion. Now, whenever you see a multi-septated effusion, this cannot be a transudate because transudate has a very low protein. They don't found septations. But in exudate, because of the high protein contents, you will find the septation. So sometimes echo picture can also help you in differentiating whether it's a transudate or an exudate. Again, CT scan is even more sensitive than ultrasound in detecting the pleural effusion. So a very small amount of pleural effusion, almost less than 100 ml, can be detected through the ultrasound and CT scan. But CT scan has additional advantages that you can see the mediastinal structures, you can see the lung which is underneath it, and even more sensitive than an ultrasound. But the problem is that it does not show us should be the management, how should we manage this patient, because it will not be able to show you septation. Septations are only visible with the ultrasound. So whenever you see a septation, either you go for a medical thoracoscopy or a CT scan or a surgical referral. So this was most important, that the ultrasound and CT scan are more sensitive in detecting pleural effusion compared to a chest X-ray. CT scan is little more sensitive than ultrasound, but ultrasound show the septations which is there underneath, which has not been, you cannot see septation on a CT scan because they are thin, they are not going to be visible on that. So determining the cause of the effusion, first you have to determine the presence of the fluid, which we have done through a chest X-ray. through more sensitive ultrasound and a CT scan. Once you find out, then you have to find out what is the cause of effusion. So how do we do that? By looking at the pleural fluid. So we have to do a diagnostic tapping, and you remove the pleural fluid, and then you have to do certain tests on that pleural fluid. Firstly, you have to see the gross appearance. On the basis of gross appearance, you can have a little bit of an idea. If it is very clear, pale color looking fluid, it is transudate. When it is a straw color, then it is possibly a malignant or a TB pleural effusion. A red, which is hemorrhagic, usually malignancy, but you can have it in other conditions like pulmonary, like asbestosis, trauma, all sorts of things which can make red color pleural fluid. White or milky chylothorax or presence of large cholesterol in the pleural fluid. Pseudochylothorax also, where there is more triglyceride in the pleural effusion. Brown color when there is a long-standing bloody effusion, and for instance, if the amoebic liver abscess rupture into the pleural space, you will find this brownish color pleural fluid. Black color, aspergillus infection, and we have also seen a metastatic melanoma into the pleural space causing black color effusion. Yellowish green, rheumatoid arthritis, rheumatoid pleurisy. Dark green, biliary thorax, that is the biliary tree has ruptured into the pleural space. Then color like enteral tube feeding. I mean, there is a communication between the esophagus and the pleural space. So that's why whatever you eat come into the pleural space. Sometimes we have seen even a rice coming out of pleural fluid because of the communication between the esophagus and the pleural space. Then pus, usually gross pus usually indicate empyema, uh, viscous fluid, mesothelioma, turbates, rheumatoid arthritis, and inflammatory proteins, NQV sauce, amoebic liver abscess. Smelly, usually due to anaerobic empyemas or due to urinothorax, where the urine leaks out from the capsule of the kidney and slightly track into the pleural space through the defect in the diaphragm. This is called urinothorax. That is urine in the thorax. So when you remove the fluid, it will be highly pungent of like urine. It will be smelling like that, although it's a very rare entity. Now, once we have removed the fluid, we have to do certain tests on these pleural fluid. So the most important is the DR examination or detailed report, in which you will see, I will show you what you have to look for DR in the pleural fluid. At the same time, you give a microscopic examination to see what sort of cells are there in the pleural fluid, which is the predominant cell which is visible on a pleural fluid, and then certain microbiological examination like Gram staining, routine culture sensitivity, AFB smear, AFB culture, gene expert. All these tests have to be mandatorily done in the diagnosis of pleural effusion. On the basis of the DR examination, where we want to find out different things, we measure different things like pleural fluid proteins. If it is greater than 3.5 grams per liter, then it is usually an exudate. And if it is less than 3.5 or less than 3, it is transudate. The other approach is to find out simultaneously pleural fluid proteins and the serum proteins. The ratio should be greater than 0.5. That is, there is more proteins in the pleural fluid, it will be an exudate. Similarly, lactic dehydrogenase, if it is the ratio between the two, that is the pleural fluid lactic dehydrogenase and the blood lactic acid dehydrogenase. So in that case, the ratio is greater than 0.6. Again, you will have more LDH in the pleural fluid compared to blood. Pleural fluid LDH greater than 2/3 of the upper limit of normal can also be sometimes taken as an exudate. Pleural fluid is classified an exudate if it meets any of the one above criteria. Conversely, if all three characteristics are not met, then the fluid is classified as transudate. So this is how, on looking at LDH proteins or sometimes simultaneously blood or serum LDH and proteins, you can find out whether your pleural fluid is a transudate or an exudate. I have shown you that in ultrasound also you can see that sometimes when you see septated effusion, you know that it is an exudate. Another few criteria which can be used as pleural fluid cholesterol. Pleural fluid cholesterol level, if it is greater than 45, it is an exudate. Pleural fluid to serum cholesterol ratio greater than 0.3. Pleural fluid serum albumin gradient, that is the pleural fluid and then the capillary albumins or albumin in the blood, the gradient should be 1.2. If it is greater, then it is an exudate. Pleural fluid serum bilirubin is also being used, not very commonly. Now, on the basis of this, we can divide the causes of effusion. These are the two major groups. One is the transudate, one is the exudate. So transudate, the common causes, whenever you find a transudate with the low proteins in the pleural fluid, the causes will be the left ventricular failure, cirrhosis of liver, hypoalbuminemia, mostly either liver failure or kidney is excreting a large amount of protein like nephrotic syndrome. Sometimes peritoneal dialysis can also be causing a loss of proteins from the blood. Less commonly, hypothyroidism, nephrotic syndrome, mitral stenosis, pulmonary embolism. Rare causes, constrictive pericarditis, urinothorax, which I have just described, is also a because your urine is always a transudate. Urinothorax and superior vena cava obstruction, ovarian hyperstimulation syndrome, Meeks syndrome, these are all causes of transudative effusion. Then we have gotten a big group of exudative pleural effusion. The common is three most important, that is parapneumonic effusion, malignancy, and TB in our country. Less common, rheumatoid arthritis, pulmonary infarction, autoimmune disease, benign asbestosis effusion, pancreatitis, post-MI syndrome. Rare causes is yellow nail syndrome, drugs, and fungal infection, where you will find an exudate. But the most common is the three things when you find an exudate. There are certain drugs which can also be responsible, particularly the drugs which cause SLE can also cause pleural effusion, like phenytoin, methotrexate, carbamazepine, procainamide, and so on and so forth. But the most important is nitrofurantoin, amiodarone, which are causing pleural effusion. Now, red cell count is also a small amount of red cell may be present, but if you see the large amount of red cell, then it is either a hemorrhagic pleural effusion or a traumatic pleural effusion. If it is an hemorrhagic pleural effusion, the causes are malignancy, pulmonary embolism, injury, asbestosis, esophageal rupture, and pancreatitis. So hemorrhagic pleural effusion. How differentiate between whether it is due to the trauma which you have caused while aspirating the pleural fluid, or it is a classical hemorrhagic effusion? What you can do when you keep on aspirating, if it is hemorrhagic, it will become less red in color as you keep on removing the fluid. But if it is a hemorrhagic effusion, it will remain the same in color without any changes. And similarly, hemocritic values compared to the blood hemocritic values, that is the level of the red cells, amount of the red cells. I mean, usually in hemorrhagic effusion, I mean, because there is a dilution with a lot of pleural fluid, so usually the hemocrit concentration will be very low, in case less than 2/3 of the blood hemocritic value. But if it is a hemorrhagic effusion, then it will be high. Now, again, the other thing which you have to see is which is the prominent cell in the pleural fluid. Whether it is a neutrophil, it is called neutrophilic exudate, and if it is lymphocytic, it is called lymphocytic exudate. Lymphocytic exudate, usually when there is a neutrophilic exudate, more neutrophil, that is a parapneumonic effusion. But if it is a lymphocytic exudation, the differential diagnosis mainly either TB or due to malignancy. So lymphocytic exudate. You can also see high level of LDH in these conditions like empyema, rheumatoid arthritis, pleural paragoniosis, never seen, urinothorax, and elevated pleural fluid, LDH. Glucose measurement also, when it is very low, Less than one third of the blood glucose level usually indicate that it is a infective in origin. The pleural fluid is infective, like it may be TB, it can be empyema. The pleural fluid is very low. Similarly, non-infective causes for low protein is empyema and malignant effusions. Certain drugs can also cause exudative effusion, esophageal rupture, uremia, subdiaphragmatic abscesses, pulmonary embolism. These are rare causes of lymphocytic exudative effusion. Another test which is done particularly to diagnose TB is adenosine deaminase, which is very high in more than 50 units per ml. So that indicates that it is a TB pleural effusion. But in our setup, it's not very useful. Sometimes additional studies can be requested depending upon the physical appearance. For instance, if you find a milky fluid, you can ask for a triglyceride and you can ask for a cholesterol in it to differentiate whether it's a chylothorax or a pseudochylothorax. Certain other special tests which are being done, like for empyema, you have to do a culture sensitivity, you have to look for a TB also. And if you suspect malignancy, you should ask for a pleural fluid cytology. Lupus effusion, again, early cells. Tuberculosis effusion, ask for AFB smear. So these are special tests which are done depending upon what is your clinical consideration for the cause of effusion. Now, after doing the DR, the second, and if you cannot make a diagnosis on the DR, what could be the possible, or if you are sure that this is the cause, usually in transudate, we can find the cause like heart failure, nephrotic syndrome, hypoalbuminemia. So we don't go for a pleural biopsy. But in other cases, if it is like, for example, let me give you an example. If it is a lymphocytic exudate, it can be TB, it can be a malignancy. So we have to do a pleural fluid cytology, but pleural fluid cytology is only positive in less than 50% of the cases. So now if cytology is negative, then again we are not sure whether it's a TB or a non-TB. So you do this biopsy, which is of the parietal pleura, which is called Abraham biopsy. Abraham biopsy, when you go to the chest wall, you will see that this is a special site of needle from which another needle comes in, which has got a curve, and like this, you put it into the pleural space, withdraw it, you will find a gritting sensation, and that is the parietal pleura. You close this, the pleura will get nipped in this space, and then you then pull it out. So you will get a small piece of pleural tissue. It is a very useful test for diagnosis of tuberculous pleural effusion, because tuberculous pleural effusion most of the time is spread uniformly over the pleural surface. So it is a blind procedure. If there is no pleural TB in this site where you have been doing a biopsy, you might miss it. Their TB might be here, TB might be there, here, here. But if it is not there, then you can miss. But most of the time, because it's a uniform involvement of the pleura, parietal pleura, you may find TB in a significant patient. Despite doing Abraham biopsy, if you are inconclusive, then there is another test which is called pleuroscopy. It's a semi-flexible instrument which you pass into the pleural space, directly visualize the cavity, and do a biopsy. And finally, we can do medical thoracoscopy. It's very similar to pleuroscopy. The only thing is that that is done by a semi-flexible sort of thing instrument, and this is done by a rigid instrument. This is then. With this, you can also break certain diagnostic maneuvers. Not only it is diagnostic, but it is also therapeutic, that you can break the adhesions and remove the fluid a large amount and do some pleurodesis. So I think I will stop here.